если там был человек с ковидом. Хорошо. И я тебя предупреждаю, что у нас еще один человек заболел, но из химиков, и не контактировал он с вчерашним пациентом. Не контактировал, он у химиков, это другое подразделение, это реально. Ну все, да. Я тебя предупредила, директору не говори, иначе нам вообще начнется. Спасибо. Спасибо. Ага, ну пока. Наталья Евгеньевна, здравствуйте. Наталья Евгеньевна, можно быстренько у вас уточнить, как обрабатывать палаты после больных с ковидом? Вы можете мне смс-кой написать, потому что у меня сейчас начинается секция? Все, спасибо большое. Ага.
Олег спрашивает, можно ли не вызывать врача?
Нет, нельзя. Извините, мы можем начинать? Извините, пожалуйста, мы можем начинать? Не слышат? Можем. Глубоко уважаемые коллеги, глубоко уважаемые спикеры, доброе утро. Мы начинаем нашу секцию, наш сателлитный симпозиум, наш семинар с международным участием, который посвящен новым радиофармацевтическим препаратам для персонифицированного подхода к диагностике и лечению злокачественных опухолей. Я хочу предоставить слово нашему первому докладчику, профессору из университета Упсалы Орловой Анне. Университет Упсалы, радиохимическая лаборатория, радиохимический отдел очень долгое время занимается разработкой новых радиофармацевтических препаратов. И Анна Орлова является одним из главных сотрудников этого отдела. И уже на протяжении многих десятилетий занимается именно как радиохимик разработкой новых веществ, которые помогают диагностировать все иные заболевания. Сегодня Анна представит нам лекцию на тему, позвольте я прочитаю ее на русском и на английском языке. На английском языке это звучит как Gastrin Releasing Peptide Receptors as a Theranostic Target in Prostate Cancer. И по-русски гастрин, высвобождающие пептидные рецепторы как мишени для тиреоностики при раке предстательной железы. Анна, пожалуйста, вы слышите меня? Анна, вы слышите меня? Извините, пожалуйста, у нас есть связь?
Моя.
Есть связь?
Да, твоя.
И я приглашаю Анну с ее прекрасной лекцией. Пожалуйста.
Да.
Анна, пожалуйста, лекция.
Вы знаете, я теперь...
Анна, пожалуйста, Анна, вы можете начинать.
Анна, у вас язык английский выбран?
Да.
Вы можете начинать.
Одну секундочку. Вы теперь меня слышите?
Мы вас слышим, да. Спасибо, спасибо.
Вы меня слышите?
Мы вас слышим.
Good
Анна, мы
morning.
слышим вас, слышим вас.
I am very glad and very thankful that I was invited.
Доброе утро. Я очень благодарна за это приглашение. Я хочу поделиться с вами опытом в терапевтических мишелях в раке простаты, гастрин, выделяющие пептидные рецепторы, являются членами семейства G-протеин сдвоенных семейства. Обычно экспрессия
And in prostate cancer, it's expressed in approximately 100% of the primary prostatic invasive carcinomas, and with in 83% in high or very high level of expression. It also expressed in breast cancer up to 70%, and its expression is coupled to the hormone-driven cancers. So detection of gastrin-releasing peptide receptor could improve staging of prostate cancer, and it's enabled patient stratification for the anti-gastrin-releasing peptide receptor therapies or in the initial stage of the therapies of the prostate cancer. So we decided to develop and the theranostic peptide for the targeting of gastrin-releasing peptide receptor. And the problem was how to choose the ligand for this. And we know that bombazine is the close analog of the gastrin and this peptide share 8 amino acid sequence with the gastrin. There is one problem with this particular bombazine ligand, that it's unstable in blood circulation, and it also agonist for the receptor and has a strong physiological function when it's administered in blood. So to improve the stability, 2 amino acids were exchanged, and the addition of 1 amino acids on N-terminus changed this peptide to the antagonist. And so we have the compound RM26 that is stable in blood and has antagonistic properties. This compound was developed under the leadership of McKem. And we decided to use this compound for our design. So for the labeling, we choose initially not a chelator. This chelator could be labeled with many different radiometals that can be used for imaging using PET and SPECT. And what we have to now decide was how to couple the chelator to the peptide. It is known that using the C-terminus, we could decrease affinity of this peptide to the receptor. On the opposite, on N-terminal, the direct coupling of the chelator moiety to the peptide would also decrease affinity. So we need a linker between the N-terminus of peptide and chelator, and we could use this linker for the modification of the biodistribution profile. So we decided to use hydrophilic linker, PEP2, because the whole peptide is rather lipophilic and has tendency to accumulate in liver with high extent. So our first peptide, synthetically produced, was labeled with indium and gallium and was characterized and demonstrated that this particular design had favorable features. So we had quite low liver and quite low kidney uptake. And we have very quick clearance from the normal organs, but we have rather stable uptake in the tumors. So with gallium, we had approximately the same pattern of biodistribution, so quick clearance from the normal organs and high uptake in tumors. So we have demonstrated that it could be used for labeling with indium, for SPECT, and with gallium for PET. We also labeled this chelator with fluorine 18 via ALF chemistry on the chelator. And we have demonstrated that on the opposite from the indium-labeled peptide, the release of the compound from the tumor was rather quick. So already 6 hours post-injection, we lost approximately half of the activity initially taken by the tumor. But however, there was quite good tumor to blood ratio and tumor to organ ratio, but this contrast did not increase with time from 3 to 6 hours post-injection, but we had very good imaging of the prostate cancer xenografts in the mice. So our next step was to investigate influence of the metal chelator composition for the imaging properties of this peptide. So we synthesized 3 additional peptides with NADAGA, DOTA, and DATAGA as chelators. And it is interesting that if we use 3 valent metals, the charge of the complex metal chelate complex would be from +1 to -1, and if we will use 2 valent metals, it will be from 0 neutral to the -2. And from our experience, we know that this charge could influence normal biodistribution, and normal biodistribution quite often means contrast. How much will be in blood, how much will be taken up by the excretory organs. So we did a series of the experiments where we tried to identify the best chelator for the different radionuclide. So we started with gallium-68, and about all of them were labeled with high yield, except DATAGA, but after purification, all of them had a very good purity and very good stability. So when we looked on the affinity of these peptides, we have found that the DATAGA chelator also gave us worse stability than NADAGA and DOTA chelators. So how it's translated to the in vivo biodistribution? So we have found that the best contrast was when we used a NOTA chelator, and the worst one was when we used DATAGA chelator. And this was +1 on NOTA and -1 on the DATAGA complex. So we concluded that the best chelator for the gallium is NOTA. What will happen if we will have longer time than gallium-68 could provide us in imaging? So we did experiment with the gallium-66 with much longer half-life. And what we have found that the contrast of the image did not improve with time for the gallium-66 labeled NOTA RM26. So the best one should be the 3 hours post-injection with very good contrast in the imaging. For chelator for indium, on the opposite from the gallium, we had a very equal affinity to the receptor for all 4 peptides. And here we have found interesting feature of this series, that the best for the short image after administration was DOTA with the highest contrast for many organs that are important for the imaging of prostate cancer. But for the later data point, the best one was NADAGA that produced the highest contrast for the blood, muscle, and this is very important for imaging of the prostate cancer in the surrounding tissues. So if we are looking on the images of the that we obtained with the peptides labeled with indium, you could see that DOTA produced the best image shortly after administration, and on the 24 hours, this is mainly depend on the contrast, and contrast will give us opportunity to visualize the smallest lesions in the patient. So chelator for cobalt was also investigated. Cobalt 55 is a very interesting radionuclide for PET imaging. And in this particular case, we had the lowest uptake in the normal organs in the, for the NOTA chelated. But if we are looking on the later data point, 24 hours post-injection, then we have found that the best retention of activity in tumor was for DOTA. And you could see here the images, micro-PET images of the prostate cancer xenografts, and you could see that that is the really best chelators for NOTA shortly after injection. It is much better for all other chelators at later data point, but NOTA and DOTA produce the best imaging contrast. So for copper 64, that also could be used for the next day imaging with, as we hoped, with the better contrast. We have found that independently of the chelator, not on ADAGA we used, we had a very high uptake initially in the tumors, but enormously quick release of the radioactivity from the tumors that dropped the contrast appreciably 24 hours post-injection. So we conclude that NOTA 3 hours post-injection would be the best chelator for the copper 64. So summarizing this study, we could conclude that NOTA RM26 is a universal peptide for the imaging of the gastrin-releasing peptide receptors that could be used for label with gallium-68, fluorine 18, cobalt, and copper. However, for cobalt 55, a DOTA chelator could be preferable for the later data point, and NADAGA and DOTA could be the best chelators for the indium 111. At the moment, we are preparing the phase 1 clinical trials for gallium-labeled NOTA RM26 that will be performed in Stockholm, in Sweden, and cobalt DOTA RM26 for imaging of breast cancer, not prostate cancer, in Denmark. So how the linker could influence the biodistribution of the peptide, we studied on the example of 4 different PEG linkers with longer chain of PEGs. And what we have found that there was no big difference in the affinity of these linkers, hydrophilic linkers, that could decrease affinity to the receptor of this peptide. And based on our publication, compound with the PEG-3 linker was chosen by the Chinese group and used for the imaging of the breast cancer and prostate cancer as well. In both cases, it demonstrated its utility and its safety that we were very glad about. So, but how we could develop compound for the SPECT imaging of the prostate cancer? For this, we decided to use technetium-99m, and technetium is cheap, available, and the most used SPECT radioisotope. So to be able to attach technetium to the peptide, we have added 4 amino acids on the N terminus via the linker. And these amino acids could be used for the direct labeling of the peptide with technetium. and technetium core. And what is essential for this is that we could develop a one-vial kit that we did for this compound. So 3 and 6 hours post-injections, the data points that are relevant for the imaging of this technetium, we had a very high and contrast of the imaging. However, we had quite high uptake in liver initial that translated in the excretion of the radioactivity in gastrointestinal tract, but we think that this is not the big problem for the imaging of the prostate cancer shortly after injection. So if we masking the activity in the rodent that is very quickly transported to the whole gastrointestinal tract, on this image we have very clear visualization of the prostate cancer xenografts. And in collaboration with Tomsk, Professor Chernov, we started the phase 1 trial based on the one-vial kit labeling. And on the preliminary data, we could see that both prostate cancer and breast cancer were visualized with this peptide. So could be this compound used for the therapy of the prostate cancer? Yes. And the treatment is challenging for the disseminated prostate cancer. Quite often it depends on the very small oligometastatic disease when we have few and very small metastases outside the prostate and just resection of the prostate gland will not help the patients. However, radionuclide targeting therapy could improve patient survival, and it was demonstrated for the targeting of PSMA. However, PSMA is more expressed on the later stages of the disease, and from this point of view, gastrin-releasing peptide receptor could be a very good target for the therapy. So we also labeled our 4 peptides with the lutetium, and we have found that on the characterization that NOTA has quite a low stability in plasma. So we exclude this chelator, this peptide from the further in vivo studies. And we found that Dataga provided the best stability in blood circulation, both without addition of phosphoramidone that inhibit activity of the peptides in the blood circulation and with it. So the characterization in mice bearing the prostate cancer xenografts, we have found that both DOTA and Dataga provided high uptake in the tumor, but Nadaga provided rather high uptake in the liver on the shortly after injection, and it also have a longer retention in kidneys that is the critical organ in the radiotherapies with the short peptides. So we concluded that Dataga containing peptide is the best one for the therapy, and we continued our investigation of this labeled peptide on different parameters that are important for the radiotherapy. For example, we investigated the uptake of in the tumor, RED1, and kidneys depending on the amount of the peptide itself, how much we inject in the patient, or in this case in mice. So what we have found that despite that with increasing amount of peptide, the uptake in the tumors decreased, the best distribution of activity was found between 100 picomole injected per animal to 250 picomole. So then the activity is more equal distributed inside the tumors. This is the autoradiography of the excreted tumors. While with the highest uptake for 50 picomole, we have the whole uptake on the rim of the tumor. With time, we have a rather quick release of activity from the tumors. However, again, when we investigated autoradiography of the resected tumors, we have found that leakage occurred mainly on the periphery of the tumor, while the core of the tumors have a very high affinity that would improve the output of the therapy. So we designed a radiotherapy study where we used prostate cancer xenografts, and we, based on the estimation of dosimetry, choose the dose of 200 picomole labeled with 60 megabecquerel of lutetium 177. There were 6 injections within 2 weeks, and we did pathological examination of after the therapy, after these 2 weeks of the injections, and at the end point of our experiment. So we had 5 groups. We had a control group PBS and a non-labeled peptide for the injected with the same amount. And we had also a labeled peptide group, and we also included trastuzumab in this study. Trastuzumab is targeting HER2 that is expressed in prostate cancer, however, in quite a low amount. It corresponds to the Herceptin test for 1+. However, we have demonstrated before this in vitro that HER2 could be involved in the repairing mechanism after the irradiation. So we had 1 control group with trastuzumab, and we had 1 group that was co-treated with the radio-labeled peptide and trastuzumab. So what was the output of this study? First of all, the non-labeled peptide and trastuzumab did not inhibit growth of the tumors and not in any way influence the survival of the studied animals. Both lutetium-labeled peptide and the group co-treated with trastuzumab had delay of the tumor growth and significantly longer survival. What was the most interesting is that trastuzumab, co-treatment with trastuzumab, added to the survival significantly, and we had this group had the longest, significantly longest survival in this study. So it's corroborate with our in vitro studies when we irradiated these cells, and we demonstrated that shortly after irradiation, the level of the expression of HER2 significantly increased in cells. And when we added after the irradiation trastuzumab, these cells had significantly worse survival than cells just irradiated without addition of trastuzumab targeting HER2. So when we investigated the tumors after treatment, so after all 6 cycles of the therapy and at the end point of this experiment, we have found that it was weak but a detectable expression of HER2 in these xenografts. When it was treated with the non-radio-labeled peptide, we did not see any difference in the expression. However, shortly after the treatment, we have a definitely much more pronounced expression of HER2 in the lesions that with time came back to the normal expression in these xenografts. But in groups treated with trastuzumab and with the peptide and trastuzumab, we could see that expression of HER2 was eradicated, and there was no expression of HER2 further in the after the development of this xenografts. So we conclude that it could be used for the treatment. However, you remember that we did 6 injections of the radio-labeled peptide within 2 weeks. That could create some problems in the therapy, and we start to investigate how we could extend the blood circulation of peptide, and this would be also step to the targeted therapy. So we designed a small compound that contains both RM26 and albumin binding domain scaffold that could bind to the albumin in the blood circulation, and in this way prolong the circulation of the whole contract in the blood, increasing its availability in the tumors for the receptors expressed in the tumors, and probably in this case we would have a better biodistribution and better profile for the therapy. When we compared this compound with its analog without albumin binding domain, we have found that despite of so huge modification of the peptide, we had good uptake in tumors shortly after injection, but we have much longer blood circulation in comparison with the peptide without binding to the albumin. So with time, the uptake increased, and it was very stable up to 6 days in the tumor. And however, the uptake in kidneys was also quite high, and this will prohibit the radionuclide therapy. However, it could be probably used for the delivery of the drugs to the prostate cancer cells, and we now are working on the next generation of these peptides for the improving the excretion of this peptide. So what other directions could be used? And nowadays, prostate-specific membrane antigen is widely used for the imaging and therapy of the prostate cancer. But however, we have to remember that PSMA expression increased with the development of the cancer, and its high expression is on the later step than for the gastrin-releasing peptide receptor. So it was developed antibodies against PSMA, but nowadays PSMA inhibiting gluey analogs are widely used and very successfully used, I could say. However, when the PSMA binder and gastrin-release peptide receptor binder were compared in the same patients, it was found that in some patients, gastrin-releasing peptide receptor was more expressed than PSMA, and images were much better for this. In other patients, the PSMA had high expression and gave better contrast. And we decided why not to combine both these targeting compounds in one compound. In this case, this compound could image both tumors with PSMA expression and gastrin-releasing peptide receptor expression. So for the binding of the PSMA, we took the DUPA moiety, this glue-urea moiety, and for the gastrin-releasing peptide receptor targeting, we used RM26. So we used lipophilic linker because it's known that this DUPA has its binding site quite deep inside the receptor. So it needs some linker and lipophilic linker to be able to stably bound inside this pocket. And we used hydrophilic linker that our experience suggests should be good for the gastrin-releasing peptide receptor and overall biodistribution. And as in the first study, we used not a chelator that could be used for different radionuclide labeling with different radionuclides. So the first generation was produced, and we have demonstrated that despite a rather moderate affinity to PSMA of this heterodimer, we had significantly, we demonstrated that it's bind to the PSMA. This binding could be blocked. Binding could be blocked also for the gastrin-releasing peptide receptor, and if we block both receptor, binding is very low. So we labeled this heterodimer both with gallium and with indium, and we have demonstrated a very good imaging shortly after the injection. However, the release of the activity from the tumors was rather quick. That, in our opinion, depends on the moderate affinity to PSMA. And we continued our study with the, investigated the influence of the linkers, both between the RM26 and DUPA, introducing the more high lipophilic moiety on the DUPA side and decreasing the length of the PEG linker on the gastrin-releasing peptide receptor side. So we have found from the series of the heterodimers that the heterodimer with the more lipophilic linker and shorter PEG linker had the best affinity, improved affinity to PSMA. Affinity to the gastrin-releasing peptide was still in the low nanomolar range. And this compound demonstrated higher uptake in tumor in comparison with our initial heterodimer, and also higher kidneys demonstrate us that affinity to the PSMA was improved because PSMA is normally expressed in kidneys. So we had a very good tumor to non-tumor ratios shortly after injection. And at the moment, we are preparing the phase 1 trial in Almazov Center together with Professor Ryzhkova. We also looked on the possibility to label this heterodimer, such heterodimer with iodine. Iodine could be used both for imaging, for PET iodine 124, for SPECT iodine 123, and for therapy 131. So we designed several compounds with the different linkers, more lipophilic in this case, and we have found that this linker was demonstrated the best affinity both to PSMA and to gastrin-releasing peptide receptors. We have found also that it was rather high and stable for the iodine label, the uptake in tumors. You could see that 72 hours post-injection, we had half of the activity still retained in the tumor. So we a little bit more investigated this phenomenon, and we have found that particularly binding to PSMA is responsible for this good retention of activity in the tumor cells, because in cell lines that express only gastrin-releasing peptide receptor, the release of activity was very normal for the iodine. However, when it was just PSMA expression, we had a very stable uptake in the cancer cells. So we had very good imaging of the tumors that express both gastrin-releasing peptide receptors and PSMA. But however, our aim to develop compound for the theranostic application was not achieved yet, because the area under curves for the kidney, due to the initially very high uptake in kidney, was higher than area under curves for the tumor. That, of course, will give higher doses to the kidney than to the tumor. So to conclude our journey, I will say that PEG-linked RM26 has a biodistribution profile that is favorable both for molecular imaging of the prostate cancer on the early stage and for targeting radiotherapy. That combination of the radiometal and chelator attached to the peptide has influence on the biodistribution of this peptide, and every radiometal that should be used for the imaging should have its specific chelator for the better contrast. The treatment of the prostate cancer xenografts with lutetium DATAGA RM26 resulted in tumor growth delay and prolonged survival, so this compound could be used for radiotherapy, and PSMA gastrin release peptide receptor targeting heterodimer could improve diagnostic accuracy of the prostate cancer. I would like to acknowledge all the granting agency, both in Sweden and in Russia, for supporting of this study, and also my colleagues who participated in this study. Series of studies, Vladimir Tolmachev, who gave us expertise in the radio labeling, Ulrika Rosenström, who produced under her supervision all the peptide synthesis were done, Vladimir Chernov, who started the clinical trial in Tomsk, Mats Larhed, who supported this project from the beginning, and the members, current and former members of my group, PhD students, Zohre Verastek, who started this project, Bogdan Mitran, who developed quite a lot of the compounds, Ayman Abuzayed, who particularly involved in the clinical trial with technetium, Fanny Lundmark, who is now producing heterodimers and to study the properties of the heterodimers, and other members of my group who also helped us with the development. Thank you very much, and if you have any questions, I would be glad to answer.
Thank you very much, Diana. Lecture was excellent, and I hope your lecture will be very valuable for our radiochemics in our PET center. They are in the audience, and I would like to ask the audience, do you have any questions? Do you have any questions for Anna?
Мы можем говорить
по-русски. Отлично. Есть ли у кого-то вопросы к Ане?
Are there any questions for Russia? You can ask the question in the Russian language. A lot of information. An awful lot of information. It's wonderful. This is the very step forward towards approach towards synthesis of new radiopharmaceuticals. So I think that what we heard, for me, as a medical doctor and person who participated in clinical trials of radiopharmaceuticals, it was a very useful and very interesting lecture. We know what we could refer to when we select the drug, the substance to make a new drug. Anna, thank you so much. Thank you.
Анна, спасибо большое. Лекция.
Well, fabulous lecture. Thank you so much, Anna. It was a great pleasure for me to hear it. Thank you so much. I'm so glad, and thank you so much for agreeing to participate. Unfortunately, we have got very small offline audience present here, that there are many people connected online because we lead amid COVID and hybrid conferences. meetings, combining online and offline. So thank you so much, Anna. We have got some changes in the program. Unfortunately, Anna Ivanova has fallen ill. Maybe we'll listen to her lecture in the upcoming conference planned for the next year. Maybe Anna will have new data about 5-4 traced by gallium-68. Now I would like to invite professor from Uppsala University. He works in the Department of Immunology, Genetics, and Pathology. Professor Vladimir Tolmachov. Vladimir Tolmachov will lecture us on irradiators with long-lived isotopes, providing us with new abilities for personalized therapy of oncology. The chair has repeated the name of the presentation. Vladimir?
Извините. Владимир, здравствуйте.
Vladimir, can you hear us?
Do you hear me?
Yeah? Yes?
Yes, we do. Yes, we do. Good morning, Vladimir.
Thank you very much.
I would like
Just
to...
sorry.
Sorry?
So I'm ready.
We are ready. Next speaker, Vladimir Tolmachov, with
Okay, Vladimir and his lecture, long-lived positron emitters, no opportunity for personalized cancer treatment. Vladimir Tolmachov is a full professor of Uppsala University.
of
Thank you.
immunology, genetic, and pathological, pathology department. Please, Vladimir.
Thank you very much. Dear colleagues, dear friends, the targeting therapeutics which act by molecular recognition of aberrantly expressed protein in cancer are very promising for treatment of disseminated cancer. Such therapeutics like monoclonal antibody might either block proliferation driving signal in tumor, or they might be used for the delivery of cytotoxic payloads. The problem is that cancer is very heterogeneous disease, and tumor of the same region might express or might not express the molecular target. Moreover, cancers are genetically unstable, and the expression could be changed during natural course of disease or in response to therapy. So in the end, we might have a heterogeneous population of metastases with different expression level, and apparently only tumors with high expression would respond to therapy, while in the case of negative expression, patients would not benefit from therapy but suffer from side effects of such a treatment. Currently, the main methods is the use of biopsy and analysis of biopsy materials. Unfortunately, biopsies are morbid and it's impossible to sample every metastasis and not possible to sample all the metastasis over time. A facile approach would be to attach radioactive label to therapeutic monoclonal antibody and observe if the antibody is accumulated on tumor or not. So advantages of use radionuclide molecular imaging include possibility to detect and actually measure accumulation of antibodies in tumors, which can be then visualized with modern imaging technique, and moreover, the fusion with CT or magnetic resonance imaging could provide the anatomical context. So this imaging is, of course, non-invasive and can be repeated frequently if necessary, and quantification of radioactivity concentration currently is relatively easy. The proof of principle for such approach has been provided by Thomas Baer and Martin Behe, who labeled trastuzumab with indium-111 in the end of past century. And they use relatively small cohort of 20 patients, but results were spectacular. So of 7 patients with elevated myocardium uptake, 6 manifested cardiotoxicity, and of 11 tumors with high tumor uptake of radiolabeled trastuzumab, all 11 responded to therapy. In one case it was partial remission, but in one case it was the full response. Of course, SPECT in that time it was even worse. It's a not perfect imaging modality, and you need to have such a big metastasis for good visualization. So the proof of principle has been demonstrated, but unfortunately the sensitivity was low, so tumor detection rate was only 45%. So it was obvious that we need to do something to improve the sensitivity. One way is, of course, to improve the indium labeling chemistry, because the method of chelation was not ideal. But another attractive approach would be to use the power of PET, higher sensitivity and better quantification, of course. The problem here was that you cannot use classical positronometers for labeling of antibody, because the optimal imaging time for full-length monoclonal antibody is around 4, 5, 6 days after injection. So you need to have a long-lived positronometer. A big step has been done by Guus van Dongen from Amsterdam, who established both production of long-lived positronometer zirconium-89 and labeling chemistry. So half-life of zirconium, a little bit more than 3 days, permits imaging 5 or 7 days after injection. The positron yield is far from ideal, or only 23%, but it's still possible. And unfortunately, there is quite a big abundance of usual gamma quanta. Still, this nuclide can be produced by low-energy cyclotron, and Amsterdam now ship worldwide zirconium, but the production can be established essentially at any PET centrum using low-energy cyclotron, and the solid-state target, which is now in custom format, can be produced by GE, and I know that GE works hard to make automated targeting agent. The chemistry proposed by Guus was based on the use of siderophore desferoxyamine or desferal or D4 which could be relatively easily conjugated to any monoclonal antibody via isothiocyanate, and labeling can be produced at room temperature at pH 7, which of course is important for sensitive monoclonal antibody. The problem is that label is not very stable in blood circulation, which is manifested by release of activity from construct and elevated accumulation in comparison with indium 111 in bone and in liver. This is not good because both bone and liver are major metastatic sites for many cancers, and high uptake in those organs reduce contrast and reduces sensitivity. Still, it's possible to visualize the HER2 expression tumors using zirconium-labeled trastuzumab 5 days after injection. I think the clinicians in this audience could appreciate this opportunity. Another alternative label is long-lived positron emitter iodine 124, which has approximately the same positron abundance, a little bit longer half-life, and can be also produced using low-energy cyclotrons available at PET centrum. The difference is mainly in cellular processing of label in case of zirconium and iodine. So after binding to tumor, but also in excretory organs, the antibodies are internalized and processed. In this case, zirconium stays inside the cells, it's so-called residualizing label, while radiometabolites of iodine leak from tumor, but also from normal organs. So iodine works only in very special cases when the internalization in the tumor and lysosomal degradation is very slow. Here is an example of antibody A33, which binds to A33 antigen, which is extremely slowly internalized. So retention in tumors is good over time. However, the catabolites leak from normal organs, and actually 2 hours after injection, iodine provides quite good imaging of hepatic metastasis. We also have applied it for another antibody, which is called capramab or Prostate. This antibody has been approved by FDA, but later on it was figured out that this antibody binds to intracellular domain, so in necrotic cells. So there is no processing. And we also have found that retention in tumors in mice is good, while retention in liver, for example, is very low, so we can get better contrast. Well, we found this in 2014, and at the same time, Uwe Haberkorn has set up new small molecule PSMA binder, so this was of very little interest, of course, for scientific community. So one could say that immunopet, the use of antibodies labeled by positron emitters, offer a number of advantages. So skillful radiochemists can relatively easy and simple convert therapeutic antibody to its diagnostic counterpart by conjugation of DF4. all toxicity data would be known and small toxicity, bridging toxicity study would be necessary in this case. ImmunoPET is very helpful during development of usual pharmaceutics because it offers measurement of pharmacokinetics over time. It can show if target is accessible for the therapeutic, and it's definitely better than nothing. We could visualize response to therapy using those antibodies. However, the major issue is that antibodies are too big. It's 150 kilodalton proteins, which extravasate slowly, accumulate in tumor slowly, and they also slowly cleared from normal tissue. To obtain a reasonable construct, one has to wait between 5 to 7 days for good imaging. Even worse, the bulky immunoglobulin tend to accumulate in tumors unspecifically due to so-called enhanced permeability and retention effect, EPR effect. And that means that we might have false positive diagnosis because of unspecific uptake. Well, fortunately, the antibodies have been studied extensively at the end of the previous century with an aim of tumor staging. And it has found that the size really does matter. One could prepare fragments of antibodies, and size reduction results in first increase of blood clearance rate, resulting in a better contrast of imaging, and also in extravasation tissue penetration rate. So the smaller the better. One should remember that if the size of the fragment is smaller than approximately 60 kilodalton, the tracer would be relatively rapidly excreted via kidney, and below 40 kilodalton, there is no EPR effect. So accumulation would be highly specific in tumors. And this has been demonstrated nicely by using so-called nanobodies or single domain antibodies, which provide a good imaging. And with the short peptides like somatostatin analogs, which show a fabulous contrast a few hours after injection. So size reduction is a way to improve molecular imaging. And antibody fragments might help to get a high contrast quicker and get it better. So one could do it relatively easily by digestion of normal antitherapeutic antibody by enzymes of pepsin or papain, which result either in formation of bivalent Fab2 prime fragments and or 55 kilodalton Fab fragments. And they have been evaluated in mice and has found that an optimal imaging time should be around 24 hours after injection. Similarly, one could even engineer the antibody, for example, by deleting the part of constant region of antibody, making much smaller constructs, like mini-body with molecular weight of approximately 82 kilodaltons, or so-called diabody, which are bivalent and have a molecular weight of 55 kilodaltons. Again, here the optimal imaging time is 24 hours after injection. Question is which one nuclide we should use for labeling. Apparently, the use of long-lived zirconium would be an overkill in these cases because you make your image 24 hours after injection. Many of those tracers have a high renal reabsorption, and long-lived zirconium would stay in so high kidney reabsorption, they would stay in kidneys and contribute both to renal dose, but also to overall dose burden to the patient. Apparently, the most optimal would be nuclide with a half-life between 10 and 20 hours. Fortunately, there is a number of nuclides which are possible to produce using low-energy cyclotron and which can offer reasonable abundance of positron translated in reasonable abundance of annihilation gamma quanta 511 keV. Of those, bromine 76 is a halogen. It behaves more or less the same way as iodine, so it can be used for in the case of slow internalization. And other ones are radiometals, which can be used by chelator conjugation to antibody fragments, and they all can be again produced using low energy cyclotron. Copper 64 is probably the most known nuclide, but my personal favorite is cobalt 55, which has the best positron abundance among the candidates and also lowest fraction of non-annihilation gamma quanta compared to the positron abundance. This has been demonstrated in mice, this immunopet using antibody fragments, and it works reasonably well. However, the breakthrough is possibly achieved by introduction of so-called engineered scaffold proteins, which permit imaging at the day of injection. So the use of scaffold protein is based on development of phage display technology, which has been awarded by Nobel Prize to Smith, who developed it, and then to Greg Winter, who applied it for use of monoclonal antibodies. Problem is that one could produce short peptide, but affinity would be typically small because of entropion issues. And solution was the use of protein scaffold, robust protein domain which fold spontaneously, often in cysteine-independent manner, and keep the structure. So those domains provide a framework for variable amino acids which are grafted in such scaffold and created large combinatorial library which could be used for selection of high affinity binder. Scaffold protein offer a number of advantages rapid diffusion in extracellular space, which provide good tumor localization of such trace. At the same time, unbound tracer is cleared rapidly from the blood, magnitude lower compared with antibody. Also, in a different way, we can ensure that we introduce a label in a very controllable way. And we know exactly where a label is, and we can modulate the effect of the label on the protein. So currently, a number of scaffold has been used and evaluated as an imaging probe. And here the scale is 1:1. One could see how smaller are those targeting protein in comparison with antibodies. And our group worked with affibody molecules, adapts, and DARPins. And our and other experience show the clear advantage of these probes. Antibody provides typically higher uptake in a tumor, but the problem is that also clearance is slow. That results in quite modest contrast. So typically the tumor to blood ratio is below 10 for an antibody. And here the is tumor to organ ratio compared for affibody and different scaffold. And it's very much clear that even 3 or 4 hours after injection, the contrast is much higher compared with antibody even 4 days after injection. Well, these are mice. What happens in humans? This is an image which says more than 1,000 words. Again, here is image produced by trastuzumab labeled with zirconium 89, the image 5 days after injection. This is an image which we have obtained in Uppsala with gallium-labeled affibody molecules 2 hours after injection. Again, I think the medical doctors in this audience could appreciate the difference in the contrast. Every black dot in this image corresponds very, very well to tumors revealed by FDG PET, including bone metastases. 2 other scaffolds have been evaluated in Tomsk using technetium label and SPECT, and again, 4 to 2 hours after injection, we have noticeably better contrast with small DARPins or adapts compared to an antibody imaged 5 days after injection. This put a requirement for radionuclide, which can be used within day of injection. In principle, fluorine 18 covers the time frame of 5 to 6 hours and can be used for this purpose. Unfortunately, the labeling chemistry of fluorine is very tricky, and it's difficult to reach good yields. There is a progress, but it's relatively slow. One could produce a number of radiometals. Gallium-68 is available through Generator, or now GE provides the direct production via cyclotron. So it probably 3 to 4 hours after injection could be used. But one could use either scandium 44 or copper 61 with half-life between 3 and 4 hours after injection, which cover whole first day after injection. Chemistry is also established, and those nuclides could be produced at low energy cyclotron. And this is one illustration what we can obtain using non-conventional positron emitter. Here is an example labeling of anti-HER2 antibody molecules with gallium and scandium. Clinical study demonstrated that the best discrimination between positive and negative tumors in clinics is 4 hours after injection. At 4 hours, it's nearly over 3 half-life of gallium. Contrast is good, but the signal from tumor is pretty poor because of the decay. Scandium was used for labeling of exactly the same antibody molecule, and the tumor to non-tumor ratio was the same as for gallium, but due to low physical decay, the signal from tumor was much better in this case. So half-life does matter in this case. Furthermore, one has to evaluate the influence of chemistry. In this study, we used different chelators for labeling of antibody molecules with a copper-64. It turns out that 6 hours after injection is optimal time, so probably copper-61 would be better. But the chelator Nadaga, which is used often for labeling with copper, provide a high liver uptake comparable with uptake in tumors. So contrast would be poor and hepatic metastasis would not be visualized. We used another cross-bridged chelator, and we have found that in this case, the uptake in liver is appreciably reduced, but still is noticeable. And putting a hydrophilic 3-glutamyl spacer, we managed completely suppress hepatic metastasis, hepatic uptake. So apparently, the labeling chemistry matters. We need to optimize the labeling of such peptide, small proteins, to obtain the best contrast. Combination of nuclides and chelator also matters. Professor Orlova has demonstrated already that for short peptide, the substitution of nuclide with the same chelator might give striking results. Here is imaging of epidermal growth factor receptor using antibody. When we used gallium-68, we had very high uptake in liver compared to tumors, so imaging of hepatic metastasis was impossible. When we used cobalt-55, we have observed much lower uptake in liver compared to tumor, both 3 hours and 24 hours after injection. So, right combination of chelator and radionuclide is essential to obtain the best imaging contrast and best sensitivity. And of course, essential overall assessment. Here is quite difficult target. It's HER3, cousin of HER2. And this receptor is expressed in tumors to low extent, but also expressed in normal tissue. So here is a gallium labeled F-body, and one could see reasonable contrast 3 hours after injection. When we tried to use FAP2 fragment labeled with zirconium 3 hours after injection, it was very much clear that there is a lot of activity in blood pool here in the heart and carotids. Increase of time to 24 hours helps to decrease activity in blood. However, we could see still residual activity in the liver, much higher than in case of F-body, but also activity accumulation in joints, in bones, and increase of time between injection and imaging to 48 hours didn't help. So the increase of activity in joint, but also in spinal cord. And imaging using full-length IgG was even worse, and the high activity in kidney and in bone was manifested. So we need to think carefully both about labeling chemistry and about tracer form. I would conclude my talk by brief take-home message that PET imaging of therapeutic molecular targets might make cancer treatment more personalized and therefore more efficient. We have several classes of targeting agents for therapy, and we can label it, and several long-lived positron-emitting nuclei offer selection of the best match between the properties of targeting molecules and nuclides. However, PET is excellent, but it's not a solution as it is per se. We need to look for good targeting agent which would contribute to overall sensitivity. And I would stress the role of right and optimal labeling chemistry. This might be indeed a game changer, and optimizing would improve the imaging and sensitivity. Thank you very much for your attention.
Thank you, Vladimir, for your excellent and very comprehensive lecture. I would like to say our audience, do you want anyone to ask Vladimir? Any questions from audience?
You can ask, well, no questions. Vladimir, fabulous, fabulous lecture. I've listened to you with great attention, very vivid examples. Everything's crystal clear. Thank you so much. For us, it was a very useful information. In a way, it was an eye-opener for us. We obtained new knowledge which will expedite our further work, because now the paradigm of diagnostics has been shifting towards immunopath, and we are fully aware of that, and we should be ready for it. Thank you so much, Vladimir. It was great. Thank you so much for you to for participation. Thanks a lot. Thank you. Goodbye. I would like to summarize. I think that this seminar on new radiopharmaceuticals for personalized approach to the diagnosis and treatment of malignant tumors is very successful because we enjoyed the presence of top-notch experts, luminaries in the sphere of radiochemistry. We received a lot of new knowledge about new pharmaceuticals and new isotopes and about the contribution of different chelators into the quality of patho-scintigraphic. So I think we enjoyed this time together. At 10:50, we'll have another symposium, no less fascinating, dedicated to nuclear medicine technologies. We'll have fabulous speakers with lectures. They have been dealing with those issues for many years on end, so don't disperse. And it will be very handy for radiochemists as well to listen to the medical doctors. We should know absolutely everything as medical doctors, and we have got natural curiosity as well. So those were fabulous presentations by Anna Orlova and Vladimir Tolmachov. We take a break.
Чего? Уйти. Егор Петрович, вам надо готовиться к карантину, а не к Казахстану. А Бог даст однозначно. Нет, Михаил